So among the safety concerns, probably one of the ones that we really look for the most are ligature risks. And these can come in a variety of both expected and unexpected forms. The door hinges and knobs and plumbing and hardware are two areas where we tend to identify a lot of ligature risks. And when you are looking for these, anything that something can be tied around that is 18 inches or above the floor and that is likely to support around 60 pounds are things that we look for. So for example, if one of the more popular items that we end up looking at would be the dispensers for paper towels, toilet paper.
Hey, I think could we ask the other field offices to mute while New York City is talking? Thank you.
So some of the items that we would look at would be things like the toilet paper dispensers, paper towel dispensers, other types of dispensers. Many of these are constructed in a manner where either the ligature would slip off because it's angled, or they're breakaway, but sometimes that's actually not the case, and they're intended to be breakaway, but they actually do not break away when pressure is applied to them. We've seen that in a number of times. Another place where we've seen that is in the cages that cover lighting fixtures. The cages that cover lighting fixtures, if they can support weight, are a very big risk. Another place where we've seen ligature risk on a CPEP is when master locks are used that have the bolt where you can possibly slip material inside in between the lock and the metal thing.
And we sometimes see burning stretchers left unattended by staff that could potentially pose, looping hazard.
Plumbing and hardware, generally in the bathrooms, we see often sinks that are not against the wall, which do present a ligature risk. Sometimes shower curtains can do the same if a rod is being used.
Okay. And then there are things, within the CPEP program space that could be used as a weapon. So, in this category we are, talking about non-temper resistant screws, and they can be found anywhere in the, in the CPEP space, whether it's the EOB bedrooms or staff offices. There could be glass that can be picked up by patients and be used as a weapon. And sometimes we see latex gloves, almost always in the garbage can, or plastic bags, right? Or sometimes we see furniture that can be picked up and used as a weapon.
Right. And with the screws, what we really kind of look out for is anything that's been repaired. Oftentimes the hospital maintenance people may not be aware of the need for using a tamper-proof screw, so where there may have been one in prior visits, when you go back, sometimes they're replaced by ones that are not tamper-resistant.
We also have to look at whether or not the space is elopement proof. And, we're looking at doors, whether or not the doors are, secure and where they are located. Security staff, what is their role? What's the process in terms of, performing their role as a security? Where the staff entrance is and where the egress is, and the entire protocol around the ins and outs of the program space. In looking at all of these different safety concern areas, I think the key thing to remember and have a dialogue with the program staff is what are what's their process of assessing for risks, safety concerns, and then in response to that, what are some of the safety measures that they put in place as a program so that these risks can be minimized?
One of the things that we see if the actual physical environment is not conducive to mitigating these risks, then the use of mirrors and cameras in areas where the risks may be more prevalent, or an increased level of monitoring by staff.
Any questions or comments?
Hi, Gina. This is Nicole Smiski from the Western region.
Hi.
How are you guys? Thanks for doing this today. Gina and Allison, I'm just wondering, you folks were talking about the breakaway for toilet paper dispensers, paper towel dispensers, etc. Are you testing the ability to break away for each of these? Are you just asking the programs if they are breakaway? I mean, is this, you said it was a point of concern. I guess I'm just wondering how far you guys take it in your experience.
If we see something that has a flat top on it, we will ask the program. I'm sure some of us will lean on it.
Mm-hmm. I think it's a combination of both. I think that it's helpful to hear from the program staff about, whether they are breakaway or weight-bearing. And sometimes staff will, during the process of the environmental inspection, they will demonstrate for us to see that they are indeed breakaway. Simple things that we can sort of check ourselves, such as the shower curtains, we may, actually test and see.
Gina?
Yes?
This is Frank from Hudson River Field Office.
Hi.
I may have missed it. Hi. But in terms of curtains, I think it was in the bathroom category you mentioned it. Do you have issues in terms of window treatments? Was that listed or mentioned?
I don't, we did not mention window treatments, but that's definitely, one area or one of the things that we definitely should look at. Because, they can, present losing hazard if, unless they're secured, behind the window or glass where, the control mechanism is available to the staff member and not to, everyone, including the patient.
So some of the areas that we would look at when doing the actual environmental inspection and some of the things we would look for, in terms of the entrance to the CPEP, we look for how far it is from the medical emergency room, whether it's near, adjacent, or in a different area of the hospital. Most often we see them adjacent, and the reason for that is, at least in the city, the majority of CPEPs clear people medically through the medical unit, and risk is assessed at that point as well, and you definitely want the CPEP entrance to be close so that transporting the patient is as low risk as possible. And also, what we're looking for is how long an emergency response from the medical unit would take to get to the CPEP in terms of if there were a medical crisis to occur on the CPEP. We also look for whether or not the entrance is Sally-ported, meaning that there are two doors that only one unlocks at a time. We look at the security staff and equipment at the entrance, whether or not there's security staff posted, if they are equipped with wands, or if there is a metal detector. We also look for the protocol and the facility for NYPD unloading their guns before they enter the CPEP.
We also look at the triage and treatment offices, both in, in a sense of understanding what the flow is like. If one was to, access the CPEP services, and also, from the safety point of view, whether or not the offices are of adequate size to, accommodate the staff and the patient for, their intended purposes, and then, where are the equipment stored, and are they stored in a safe and accessible manner, and also whether or not these offices offer, privacy. EOB beds are also what we look for in terms of the privacy, comfort, and adequate number of EOBs. I think in New York City, most of them have 6 EOB beds, which is the maximum allowed. And we also look at whether or not these EOB bedrooms, are used to, store restraint beds, and what the general process is, for the CPEP program when they need to, have an individual in a restraint. The location, much like the CPEP in relation to the emergency medical room, we, expect that EOB beds are located either in or adjacent to CPEP so that, we can ensure that the CPEP services are provided in an accessible and adequate manner. Sometimes, and we actually have a number of CPEP programs that do not have their EOBs in the CPEP program space, but upstairs in one of the units. And this is something that we review in terms of a plan for the location and how they will provide adequate EOB services while being away from the CPEP.
We also review the nursing station, and in the newer constructed CPEPs, a lot of the nursing stations are centrally located so that the staff can see all of the possible angles of the CPEP. In the older ones, they really aren't, and in those cases, you would be looking to see whether the nursing staff can actually monitor the CPEP from where they are. The other thing we look at is whether or not there is plexiglass between the CPEP proper and the nursing station, whether it's full or partial, whether patients have access to staff.
Yeah, and I think in looking at the nursing station, we what we want to see is that it's not only safe, but it's also welcoming and engaging. Something that would really encourage the patients to interact with the CPEP staff, and how easy that is to accomplish. We look at bathrooms, and the safety and privacy is really key here, and whether or not the CPEP space offers adequate number of bathrooms for the patients.
We also look at the various waiting areas that CPEPs have. In many of our CPEPs, there are different areas for waiting. For example, CPEPs sometimes have an unlocked area where patients who are coming in, who have been triaged as not being holdable in the CPEP, who are just coming in for med refills, they would stay in that waiting area. We look that there is a waiting area for family members, a separate waiting area for children if there are children admitted to the CPEP. We look for adequate furniture and space, which also lends itself to the whole discussion of milieu, which we'll talk more about later, because there's nothing as agitating to a person who is in crisis to be crammed in in an uncomfortable environment with a lot of other people. The other thing that we see that we definitely make note of is if there are any stretchers in the hallway, which can happen if there's an inadequate amount of furniture and space, but we do actually see that sometimes.
Any questions or comments?
Yes, it's Frank again. In terms of the collaboration with the New York City Police Department, have there been any issues? It sounds like maybe there's an agreement, or the hospital has an agreement with the police department to give up their guns, because we've had discussions in our region where the police have not been willing to give up their weapons. In a few so it sounds like it's not been an issue in New York. Well, they don't give it up. They take out the voter.
They do give up their weapons. They unload them before they enter the CPEP space, and as far as we can remember, we haven't had any difficulty in terms of, getting the NYPD officers to agree to do that. However, I think Tony may have a prior experience with something.
We had an issue like that in the children. It's the equivalent of a CPEP in another state. And what we had to do is we actually had to get the statutory requirements and bring it to the local precinct and sort of work on the relationship with them. And once we did that, then that was a very difficult battle. But once we did that, then it wasn't an issue anymore.
Mm-hmm.
Okay. A second question is just in terms of a compromise between walling off the nursing station with plexiglass versus being open for engagement.
Mm-hmm.
Have you seen that kind of a compromise that satisfies both?
Can you repeat the last part of your question, Frank?
Yeah, I mean, you're looking at, the extent of maybe plexiglass at the nursing station so that that area can still be viewed by staff. And I imagine some of it might be also for safety of the staff.
Mm-hmm.
You also mentioned a need to be welcoming and engaging. So is there a compromise between the two?
Yeah, I think in
the
this...
partial plexiglass might be compromised. But.
Yeah, right. So there's the option of partial, glass that only come up, I don't know, so high rather than all the way up to the ceiling. But, when we engage in these conversations with the CPEP program is that whether or not, so it definitely is a safety issue. I mean, we have had incidents where, patients went up to the nurse's station, just picked up a computer monitor and just, threw that against the staff. So it does become a safety issue. But, we also encourage the providers to look at, some of the, the related incidents and what were the circumstances. Were there other factors that could have, prevented or they could have led to such a incident? So, it could be looking at the staffing, whether or not the staffing was short or adequate, what was kind of occurring around the time of the incident becomes a helpful discussion with the CPEP program.
Okay, thank you.
Any other questions or comments?
I have one more question. It's Nicole again. Tony was just speaking about essentially working with the police departments in response to Frank's question about them carrying weapons or whatnot. I guess I'm just wondering, did you folks at the field office have that discussion, or were you encouraging of the program or agency itself to have those discussions? I guess I'm just wondering what role you guys played.
Yes, so the example I gave was from another state.
In his
I apologize.
he was referring to his prior experience.
Oh,
you know,
okay.
before he joined OMH. But
Right.
I would imagine that, you know, we would be involved, you know, somehow, you know, in that effort.
In the Hudson region where that's come up, we haven't actually gotten involved in those discussions, I don't believe, but we did encourage the hospitals to work with the local police to come up with a resolution. And ideally, they would not, you know, take their weapon on the unit. In terms of a discussion of not a CPEP, because we don't have it. Discussion with an inpatient. And, you know, I'm trying to think of what the resolution was. It might have been down in Rockland County where that had come. But there was concern that we had about the officers taking weapons on the unit. And it would seem that the police officers' regulations, requirements, and procedures, you know, might preempt what OMH would ask for, have that ability. That was my understanding. And I asked my staff, if those of us that are here, what the resolution was. I'm not,
This is Carol from Western. I know we've run into this with a couple of hospitals, and one in particular indicated that they needed to work with the union that was overseeing the security that carry weapons, mace, and I don't know if that ever has been resolved. And in another hospital, General Hospital, psych unit, the local sheriff's department insists on bringing their weapons on site. They claim because when they come on site, they believe a crime has been committed, and they are required to bring their weapons, and they have not been able to resolve that.
We've had, this is Walter, police have agreed to meet within the Sally Port, so if they were to pick up a patient, then they would meet between the doors, and that seemed to satisfy that program.
I have, this is Victoria, I have one question not related to the police, if I might do that. You were talking about the EOB, and if I understood correctly, you said that sometimes it's located on a separate unit. And I was just wondering if you could speak briefly to the staffing expectations for that. You know, would it be CPEP staff? Would they be using unit staff that would be partially assigned to the, you know, EOB CPEP program?
We've seen both configurations. When the EOB is located on the inpatient unit, in some cases it's almost a discrete area of the inpatient unit, and then it is staffed by its own staff, by CPEP staff. But we've also seen where it is part of the inpatient unit, meaning that it's a couple of rooms on the inpatient unit, and in those cases we expect to see enhanced staffing on the unit to provide appropriate monitoring for the individuals in the EOB, and also we expect those individuals to have access to activities of the inpatient unit.
And the enhanced staff would be then basically assigned to the CPEP or clustered to the CPEP program?
It really depends on the unit. They can assign a staff that would be brought in to supplement the inpatient unit staffing. Usually it's more often that than it would be someone being sent up from the CPEP.
Okay, thank you.
So the next area we look for when we are doing the environmental inspection is for evidence that patients' rights are being maintained and respected, and the way we would look for that are day and evening hours posted, are patient names visible at the nursing station. Sometimes what we'll see is you look in the nursing station and someone's chart with their name on the spine of it will be sitting there, or someone will have their name written on a board. so that we also look to make sure that there's controlled access to the case records. We will also look upon inspection of the nursing station if the restraint documentation is maintained separately, which it often is. We will look to ensure that patients are fully debriefed following episodes of restraint. Again, we'll also look to see if patients are provided a confidential space to meet with family or other collaterals. And again, that patients who have not been admitted to the CPEP proper have a place where they can wait comfortably.
So the next area of CPEP environmental review is, looking at how the CPEP program is offering, the required treatment services, and whether or not the CPEP space is supportive of, the program's ability to do this in a safe and effective manner. So some of these things came up before. We looked at the restraint beds and where they are stored and how they're used. Same thing for medical equipment, hospital beds, and medication storage is, a very important area for our review, and it's often, part of the nurse's station, or they have a separate medication room, within the CPEP space. Point-of-care testing, crash cart, group activities in terms of where they occur and whether, the space is offering safe and, effective, whether or not the space is supportive of all of these things to occur in a safe manner is what we look at. Staff on the, unit of CPEP, I think this is something that we look for, in understanding what is their interaction like with the patients, whether or not, staff are, all at the nurse's station where, not engaging with the patients, completing paperwork. So we look for that interaction, staff presence, and what is the nature of the interaction, with the security staff and the patients, as well as something called VHAs, which I believe could be a New York City, something that's unique to New York City, perhaps not, but these are behavioral health associates who are staff who are not professional or clinical, but, who are very well trained in verbal de-escalation, crisis intervention, and they offer an excellent assistance and support for the clinical staff working with the patients in a very acute setting, such as CPEP or inpatient units.
One of the recent moves by a lot of the city hospitals is to replace much of their security staff with BHAs to create a less intimidating environment. In some hospitals, you'll see security staff in uniform with a very obvious presence on the unit. And in the hospitals that have transitioned to more BHAs, these are people that are dressed in their street clothing, and they basically, their presence is very obvious too on the unit, usually in the hallways, checking in with patients, and if de-escalation needs to occur, they are on the front line of doing that. One of the things we also look for in regards to the crash cart, and that we actually see quite often, is that the crash cart is not accessible to the unit. So what we look for is where is it being stored. Oftentimes it's behind some other equipment, or in one case I recall it couldn't fit out the door. That it was in an office where it couldn't fit out the door without taking the door off the hinges. In some cases, we've seen it stored in the medical ER, in which case it would take a fair amount of time to get to it and to bring it into the CPEP. So we will often even trace the path that it would have to take to get from wherever it is to an emergency that is occurring on the unit.
Any questions or comments? No. Okay, so
Actually, you know what? I have one more question. I'm sorry. I'm typing up again. What about with regard to locked doors? Are there certain areas that you would anticipate should be locked at all times? You know, I know that we're focused a lot on hardware of the doors to make sure that there's no looping hazards, but I know, you know, even with the door handles, I think there's concerns that, like, for instance, bathrooms and whatnot, you know, should those be locked? Should those be consistently unlocked? Any advice or feedback you can give?
well, I think that, you know, I mean, there are doors that we usually see locked and we want to see locked, and there are, you know, medication rooms or nurses' stations. Simply because, you know, we would not want to, you know, I mean, there are things that the program should be, you know, maintaining in a secure manner from the patients. But I think that we always sort of look at the program's policy and rationale for whether their decision to keep certain doors open or closed. And also, you know, in doing that, you know, I think it's important to just understand the level of potential risk by leaving them open.
Generally speaking, unstaffed areas will see locked until there's staff intervention. For example, if there is a laundry facility, unless there's staff presence, that will be locked. Same with linen area is often locked. Fire extinguisher doors we see locked.
Okay. I have two more questions, if you guys don't mind. You spoke briefly about the bathrooms, and I'm wondering if you have any recommendations on how we can become more familiar with, for a shower area, the breathability of shower curtains, because I think that's something that's come into question of whether or not we feel comfortable with what's being used.
Yeah, no, I think you bring up a really important point. Sometimes, you know, we're asking the question to the CPEP program staff, you know, are these curtains, what's the breathability of these curtains? Can it be, and you know, we're asking that question, you know, in order to understand the risk. And, you know, it's helpful when the program is able to tell us. It's not so helpful when, you know, we don't have the answer. But I think this is something that we could, I mean, I'm going to look to the group in central office, other field offices for ideas or discussion in terms of whether this is something that the safety committee can you know, look into, or I guess, you know, what I'm trying to say is what is the best way to determine, you know, the breathability question.
Gina, we can ask them for the specifications of the materials that they're using.
Mm-hmm.
Carol, would that indicate, the specifications, would it indicate breathable
Yeah.
versus not? Or,
Yeah.
okay, because I just didn't know if we had a reference point to compare whatever they were going to give us
No,
to, but if it would
actually
indicate.
I've actually had them present that and demonstrate that the packaging indicates that it's breathable.
Okay.
So it's either it's breathable or not. So it's not, there's no like rating or percentage that's in question?
Not what I saw. It said breathable. It didn't list a variance of how much. So I think you can ask for that, and I have done that before.
Any other questions?
I have one more question. With regard to the activities that we see being available in CPEPs, I know one of our CPEPs has both an adolescent area and an adult area within the CPEP proper, and we frequently have seen that the adolescent side is loaded with activities and just things that people have access to, and essentially the staff talk about, ongoing supervision to make sure that, nothing's ingested or, anything like that. On the adult side, we see a highly discrepant availability of activities to be doing, and we only see typically newspapers. I'm thinking last time that I went into the CPEP, I also saw, excuse me, sheets that people could color on with crayons, and I'm just wondering if anybody else in the regions has any thoughts on if you've seen maybe more extensive availability of activities for adults to be utilizing while there.
Unfortunately, we generally don't see a whole lot of activity available for people in the CPEP. Frequently, there'll be a room with a large TV in it, but we don't. When there's an activity program for people who are on the EOB, then there may be a more robust programming, but that's a frequently cited issue on CPEP.
Hello? Laura Mandel has some comments on that issue.
Yeah,
Laura?
hi everybody. Stony Brook on Long Island went through a pretty major transformation both with their adult side and the youth side of their CPEP. When I first went there, it was a newly renovated unit, and it's sterile and just kind of quiet and controlling and not therapeutic. And when I went back a couple of years later, what we saw was it felt more like a day program. It felt more like a CDT. Immediately when you went in, there were people sitting around, there were staff with them, there were people wearing headsets, there was an activity cart, there was patient art on the up on the walls, inspirational sayings on the wall, the mural, and the kids side had nice, there was like some, I don't know if it was bean bags, but there was nicer seating, and there were lots of games and activities that could be done even when there wasn't an activity therapist. So I think that it really depends on someone at the CPEP championing this, whether or not you have a full-time activity person or a rec therapist. If someone is championing it and has management support, there can be a whole lot of activities that are pretty low risk, especially if there's a strong staff presence. So it can be done. And again, I haven't been to Stony Brook in quite a while. I don't know if anyone is on the phone who's been there since I was, but they really stepped it up.
We have a visit scheduled shortly, next month.
Oh, great.
So this is Victoria. I have a question about something that was mentioned on one of the slides back. I apologize, it's not specifically the milieu. It was about med refills, people coming to the CPEP for medication refills. Is that only for emergency refill, somebody who's in crisis that needs an emergency refill?
We would hope that that would be the case, but actually what happens more often in the city at least is that people run out of their medication and cannot get an appointment at their clinic, or their psychiatrist is not there that day, and they present at the CPEP in need of medication refill. And often they are patients that are known to the CPEP because this is not the first time they're doing it.
So then I would imagine that would be something that, we'd be looking at as far as, the review, what the practice is, what the services are, and how that can be addressed other than the CPEP?
That would be the discharge plan, hopefully.
Okay. Thank you. This is Carol. Early on in the presentation, you talked about areas that might have a camera viewing them if they weren't in line of sight with the staff. What I've run into with that sort of thing is then no one sitting in front of the monitor that's watching the video.
Well, this is something that we would also pay attention to if there is a monitor sitting at the nursing station with no one in front of it. That would be something that we would call to their attention. We don't see that as often in the newer CPEPs because there is a view from all of the angles.
Okay, thank you. But yeah, this one didn't, and they said that they didn't have anybody sitting there all the time, but that folks were glancing at it. But unfortunately, they also had a suicide attempt in that particular area later on. So we just can't expect that they should rely on the cameras.
No, you're absolutely right. And it's helpful when we ask the question, what's their policy on it? Who's responsible for monitoring the footage, and what they do with it is a very interesting way of learning, what their system is like.
And Gina, kind of speaking to that, I guess I'm wondering how your field office manages when you have a situation where there is maybe an area of a little bit lower risk or more moderate risk as opposed to a high-risk area, and there may be, whether it's a ligature risk or just a safety concern, and you are asking them to provide their policies and talk to you about how they mitigate those elements of risk. Do you then bring that information back and discuss it as the field office to say whether or not you're comfortable with it? Do you rely on the lead reviewer to then decide whether or not that's going to show up in the more? Because I'm thinking, even if there is a policy and it seems like it's a good idea, if we are not necessarily indicating that on the report that goes to them, would that be negligence on our end? Just because we have identified a risk, whether they've got a policy or not about it. I'm just wondering if you can speak to your experience.
Well, when anyone identifies something like that, it will end up on the more as a comment at least. For example, if we, upon our inspection, note that there is let's say a BHA or security stationed on a hallway, and there are parts of that area that are moderate risk, and they're not walking them. Even if their policy says this person is monitoring that area, if we don't see that occurring, then we will make a note of that. That although this is the policy, upon observation, it was noted that there were areas of the CPEP that were unmonitored during the time of the visit.
Thank you.
So I think we started to touch on some of these, issues that would really help ensure a safe and effective CPEP environment. Overcrowding in New York City, in particular, is a big issue, and this can lead to so many different concerns. What we would expect is that each CPEP has their, coming back to the policy issue again, that, when the CPEP, goes over the maximum capacity, that they have a plan in place. And often that plan is to, go on diversion so that, the overcrowding issue doesn't become any worse.
We'll also observe, and this occurs again in CPEPs that have a number of different areas for waiting, that overcrowding can be going on in a particular room. For example, if there are a number of waiting areas and one of them has a TV, what we've seen is that one or two of the areas will have absolutely no one in those areas, and that the room with the TV will have 30 people in it, which definitely does not create a comforting environment for those people.
Right.
And that really feeds into the whole second element, which is the whole ambiance of the CPEP, and that's something that we pay particular attention to because, it's a tense environment to begin with. If you walk on and things seem under control as opposed to not under control, there's a huge difference in terms of the patient experience of that. And what we found is a lot of that does have to do with space, so that everyone has their personal space and has enough room to create space around them and not be impinged upon. That there are separate areas if someone needs to separate themselves from the main CPEP and maybe turn a light out. When CPEPs have that capacity, it definitely will add to the overall maintenance of a therapeutic milieu for the patients. And as we were saying before, the whole presence of staffing, whether staff appear to be there in an enforcement role or in a kind of disincentive role, or whether they're there in a supportive role. And you could basically see by the body language and the manner of interaction between the staff and the patients. I think that one of the last reviews that I did with the CPEP, what I noted was that there was this beautiful nursing station that had full plexiglass, and there were more people in that station than there were out on the unit, including the patients. So there was 20 staff in the nursing station, and none were out on the unit, and it really did make a big difference in how that unit felt.
Much like any other program space that we license, we look for smoke detection and firefighting equipment and general cleanliness. Whether the environment is really warm and inviting or is it very institutional and sterile. And there are things that the programs can do differently and creatively to, make the space very inviting and therapeutic. Temperature, this, I think we all sort of have an experience, whether it's a CPEP or clinic or wherever we went for a review, that the temperature wasn't adequate to the weather. And this becomes an important issue because, patients tend to stay there for, as we know, up to a couple of days at a time. So we want to make sure that they're, they're staying there and the temperature is comfortable. Psychoeducational materials, that it's not all about board games or, in the CPEP space, that there are things that are available for the patients or visitors to educate themselves on, issues relative to mental illness or symptoms or service, resources, right? Information about what resources are out there once they leave the CPEP. And again, inspirational art or things that they can do to paint the walls in different colors, and little things can make a huge difference in settings such as CPEP, where it can be really stressful for both staff and patients and visitors. So, anything else, Alice?
The puppies.
And the puppies. I would have liked kittens, but any questions or comments?
Gina, I just have a question about the space. Do you take out a tape measure and just go all over and to measure the spaces in each room?
No, because that's what you do, Rudy, before CPEP's open.
Okay, all right. All right, now I was just wondering, so you don't have to go in and make sure that they have only, for instance, only one bed where there should be only one bed or two beds?
Yeah, I think the, what we remember when we're walking around is, how it feels, right? Individual offices, I think, we're pretty comfortable in terms of, kind of knowing or gauging whether this room is of adequate size or whether it's too small. And that, even though we review the proposal, including the size of each of the rooms before the programs open, which was my point earlier, I think things can definitely change after they open, especially if, the volume of patients or staff that they get is so high that they have to make environmental changes, and that in turn could really change the safety level of the entire program space. And I think it's really important for us to pay attention to that and be able to address that with the program staff. So, basically, if we walk into, a room, an exam room, let's say, and it feels too small, then we would ask for the dimensions and then understand whether the room is holding, more than, whether it's equipment or furniture or people, than it should.
Right. Okay. Thank you.
Gina, this is Laura. You have a couple of CPEPs down there that have converted seclusion rooms to comfort rooms. Is that right? There's at least a couple of HHC hospitals.
I think you are right. I don't know if we have any CPEPs that actually have a seclusion room, or at least the ones that, that use that room as a seclusion room. But yeah, that definitely the trend has been to, have something available where, it could be used as a comfort room.
And can anyone speak to what they're seeing out there with regard to any CPEPs that have what they call a comfort room? Is that room locked when not in use? Are there things in the room that where they really feel like it needs supervision when it's being used, or is it just open?
So for us here in New York City, I think we're, we're still sort of in the process of hearing more and more about, their intention to create this or, convert a room to make it a comfort room. But I don't believe that we have seen, the comfort rooms being used, kind of, fully and as designed.
And Laura, in response in the Western region, sorry.
I'm sorry. I was going to just add on the inpatient side, the comfort rooms are, more sort of in use, and I think there's a better understanding in terms of what that should look like.
And Laura, I was going to say, in the Western region, unfortunately, I'm crunching my brain, and we have so few of these programs that we visit that I'm not recalling accurately, but I believe that at ECMC, the room that they have there's over on the kids' side, they've discussed, using it more for when people just want to go and kind of have their own space. They can use this room that's been designated for seclusion, and then they won't close the door, and it would be open. But I don't think that anybody has access to it unless they request it. And even if they do request it, there is nothing in it.
Yeah, and that is something that has had a little bit of controversy. I think central office has not really supported the use of seclusion designated space for relaxing or sleeping or comfort. But we know that several have been used that way.
Gina?
Yes.
It's Frank. Were you going to say anything about the other services? I know you mentioned the extended observation beds here, but the other required services such as, crisis residential services for transition to the community, or crisis outreach services, anything, or is it, I know your focus is on the environment here, but what do you look for in terms of the crisis residential, because that might be in the community?
Yeah, that's right. So as you said, we focused on the CPEP space, so where the emergency, services are provided and where the EOBs are located and the EOB services are provided. But I think the general approach to looking at, mobile crisis is that we may look at their office, but, because we understand that they go out and deliver the services in the community, and there's rarely, almost, I don't think they ever see any patients in their staff office. So there's not much of attention paid to the safety of the staff, office that the mobile crisis teams use. And then on the crisis residential side, at least for us here in the New York City region, all of the crisis beds, for those who have the beds, are in a licensed CR space. So, we kind of understand that they, they met the at least the program space requirements per the CR regulations or expectations. So I think that's sort of the general approach that we take. But, the primary emphasis really is on the CPEP proper and the EOB areas.
All right, thanks.
Any other questions or comments before we end the recording here?
Just one comment. You might have mentioned it in the beginning, but CPEP regulations, in the New York Code Book of Rules and Regulations for 14, it's Part 590.
Right.
Yeah, I don't know if you mentioned that for the newer staff, just so that they know what part it is.
Oh, I did not. I don't know if we mentioned it, but you're right. So the regulations for CPEP premises is Part 590.13.
This is Carol. I just want to thank you, Gina. This was really very helpful.
Thank you.
Yes, thank you very much.
Thank you. Okay, so I think I'm sorry, Beth had a question. Go ahead.
I do, yeah. Well, as far as having a welcoming environment, the most common complaints I have heard from patients and that has stopped them from going to the CPEP is having to be in gowns and then not being able to get their clothes back if, even if they're in there for 24 hours. And then they can get them back, the minute they get into the inpatient unit. I'm wondering if anybody has had the experience of, I know this happens somewhere, but I don't know if it happens in New York State or New York City anywhere, where patients can get, clothes back once they've been evaluated.
Yeah, we haven't really seen that. Any thoughts on that, other field offices, if you're still on the phone? Yeah. Okay, all right. Well, so we're going to sign off unless there are any additional comments or questions.
Thank you very much.
Thank you.
All right, so we'll end the recording. Thank you.
Let's